Good afternoon, everyone, and welcome. I am William Callow, Associate Professor of Public Health Sciences and Family and Community Medicine at the Penn State College of Medicine, and Advisory Board Member for the Emerging Leaders Program. It is my pleasure to showcase the wonderful work of our 2025 cohort of Emerging Leaders Fellows. The Emerging Leaders Program was created in 2023 for diverse early career professionals to enhance their skills, tools, and habits to amplify leadership qualities by shaping the future of HPV vaccination best practices and outreach, capitalizing on monthly mentoring and learning opportunities, and networking with national HPV vaccination and public health leaders. This year, despite the challenges to HPV vaccination, the fellows have been able to accomplish so much, and because of this, we relish in the opportunity to showcase their work. This group consists of 16 fellows from across the US who have passion for improving HPV vaccination. During the next hour, you will hear from 4 groups of their capstone projects. Each project focuses on a priority population relative to starting HPV vaccination at age 9. Today, each group will present within 15 minutes. Please enter all questions and comments in the chat or the QA. We will answer all questions following the 4 presentations. Before we begin the showcase, I want to address a few housekeeping issues. Today's showcase will be recorded. The link to view the recording will be shared with all who have registered. If you have any issues during today's seminar or have any questions for our presenters, please use the chat. To ensure that there are no disruptions during the presentations, all participants have been muted by the host. We will have a Q&A portion at the end of the showcase, so please put your questions in the chat. To start the showcase, we will have our first group who will be presenting on leveraging dental health providers in rural areas for HPV vaccination at age 9. Let us welcome Heather and Nicole.
Next slide. So first, just to provide a little background information on rural America and to kind of characterize it a little, we see a slightly higher percentage of people without a high school diploma and those under 18 who are not insured in rural populations compared to urban. We see a larger difference when we look at household income in these populations. In rural populations, it's around 62,000 compared to 84,000 in urban populations. We do see that approximately 84% of children in rural areas have seen a dentist in the last year. And while this is a little bit lower than that in the urban populations, it's still really great to see that the majority of children in rural areas are seeing a dentist every year. Next.
So when we're looking at vaccination rates in rural America, we see a correlation between states with large rural populations and low HPV vaccination coverage. And as you can see on the slide, the rate of completion in each state's rural population was lower than their overall state average. Next slide.
Now moving into looking at HPV-associated cancers, there were just over 39,000 cases caused by HPV each year. And HPV-associated oropharyngeal cancer has surpassed cervical as the most prevalent HPV-associated cancer, and it's far more common in men than in women. Next.
When looking at oropharyngeal cancer incidence rates, we see here that some of the states with the highest rates of oropharyngeal cancer are also some of the states with a large rural population and low vaccination rates, including West Virginia, Mississippi, and Kentucky, and those states are highlighted in red. Next slide.
So just building off of what Nicole said, we can look at the rural-urban disparities where we see a significant difference in the rates of all cancers, HPV associated, and then specifically oropharyngeal cancer, with higher rates in the rural populations compared to urban. Next.
There are some unique challenges and attributes that come with vaccinating in rural areas. For example, people in rural areas tend to have a higher level of vaccine hesitancy compared to urban areas, as well as lower perceived risk of HPV infection and less knowledge about HPV and the vaccine. Rural providers also describe a sensitive patient-provider dynamic as personal choice is held in high regard in rural areas, but patients in these areas tend to have longer-term relationships with their providers, so trust is really key in these relationships, especially in rural areas. Next slide.
So when we look at the literature, we see that overall, patients are comfortable discussing the HPV vaccine with their dental provider, and they have pretty positive perceptions about their role in HPV education. We do see that patients who have a prior knowledge of HPV and the link with oral cancer have more positive attitudes. However, few patients report actually receiving a vaccine recommendation from their dental provider. And then again, like Nicole said, specifically in rural populations, we see a strong value of personal choice and independence when making healthcare decisions, especially in the choice to vaccinate. And then for dental providers, research shows that they believe discussing the HPV vaccine is within the scope of their practice, and they're willing to recommend and refer their patients for the vaccine. To prepare for these discussions with patients, dental providers have requested more information about HPV as well as the HPV vaccine, training and tools to be able to have these discussions. And then again, kind of focusing in on rural communities and this patient-provider relationship, it can be an asset in that patients generally know their provider pretty well. They see them maybe for a long period of time and typically follow what their provider recommends. But that can also be a challenge in potentially small communities where you may see your doctor at the grocery store, you might sit next to them at church every Sunday, and that can kind of hinder those true and honest conversations that you might have. Next.
So this slide's a bit more visual of what Dr. Owens just went over. And when we're examining the role that dental providers play in HPV prevention, currently there's only a few states that allow dental providers to vaccinate. And even within those states, the rules vary between which vaccines they're able to give out. So broadly, their role is mostly in education as of right now. And in an American Dental Association survey that was collected to show these numbers on the slide here, only 31% of respondents indicated that they are currently providing patient education regarding vaccines, but another 35% indicated that they were considering providing vaccine education. So this suggests a desire to engage in HPV and other vaccine education and awareness from the dental perspective. Next slide.
So based on this literature and what we've kind of seen, we've identified a few gaps for our project. The first is there are limited materials specifically for the dental setting. Additionally, current age 9 materials are not specific to either rural populations or the dental setting. And then finally, we need additional resources around vaccinating at age 9 in these rural communities. Next.
So for our project, we wanted to create some materials that could be used by these dental clinics in rural areas to help educate their patients and families about the HPV vaccine and the links to oral cancer. This toolkit has the potential for broader use beyond rural areas, but when we were creating the toolkit materials, we developed them with rural beliefs, attitudes, and capacity at the forefront of design. Specifically, radio ad campaigns are widely used and cast a broad reach to rural communities. So we did develop a customizable radio script that could be tailored based off of whether your state vaccinates or not, whether your office decides to vaccinate or not. And then we also created a 9-year-old birthday card with info about HPV, as well as vaccine reminder scripts and a guide on how to use all of these materials. Next slide. So this is the front page of our toolkit. And as I mentioned, this toolkit includes all of the materials as well as background information about HPV. ACS has a great dental guide, and so we included that as a link to get folks kind of started and interested in why you should care about and promote the HPV vaccine, and then kind of took it a step further with some additional resources like the radio scripts and the birthday card. Next slide. So listed on the slide are some of the most common myths about HPV in rural America, and we address these myths and sample responses in the toolkit. And these are just some examples of the ones that we put in the toolkit. And we offer opportunities to dispel some of these myths in the radio campaign. So as I mentioned, it's very customizable. There's a section that lets you put in your own myth depending on what is the most prevalent in your specific area. Next slide. And then we also included some general vaccine myths and perceptions to help address broader vaccine hesitancy when talking with patients. So some of these do overlap with common myths about HPV, but we wanted to make sure that dentists are having these kind of broader conversations to boost vaccine confidence and lower vaccine hesitancy overall. Next slide. And then this is one of our main materials that we created. This is our birthday postcard, and it's a great tool to wish a patient a happy 9th birthday, and then segue into talking about the HPV vaccine and why this is the best time for a patient to receive this vaccine. The postcard is very simple. It explains how HPV relates to dental care and why your dentist is sending you a postcard about HPV. And it also highlights personal choice. So again, this was something that was really common in rural areas is they want to make their own choices. And so we highlighted that in the postcard. It was designed on Canva and can be completely customizable. So there's a lot of space to add in your own information for your dental practice. And then there's also the ability to order the postcard directly from Canva, making the process really easy for users. And that whole step-by-step instructions is outlined in the toolkit. Next slide.
And then for our radio campaign, we developed a script that, as Nicole mentioned, it can be tailored to address a common myth or maybe a specific perception in that community. We also made specific scripts for states who cannot vaccinate, which is shown here on the slide. And then we also have a different script for those who can vaccinate, where the dental office states the vaccine can be given at the child's next appointment or to call their office to schedule an appointment for the vaccine. Next. And then similar to the radio campaign, we have scripts for the office, and they can be used as either an email or a phone reminder, and it's again centered around the child's 9th birthday. Our toolkit also includes a shortened version of this that can be sent as a text message. And this would be for clinics that have those texting abilities and maybe send out appointment reminders or other things to their patients. And again, we have 2 versions depending on the state's ability to vaccinate, and then also 2 if the clinic chooses to vaccinate. Next. And so within our toolkit, we've included instructions on how to edit and customize everything. So on the left side of the screen, we have provided screenshots with instructions on how to edit the birthday card in Canva. We realize maybe not everybody is as well versed in Canva as Nicole is. So we provided some screenshots on how to do that, and then also to how to print from Canva. And then for the various reminder scripts, as well as the radio campaign, we have the text listed, and we've noted within it where to kind of add their own specific information and things like that. And then again, the materials are divided between their ability to vaccinate. Next. So just to kind of wrap up, we've started some of our planned evaluation of our materials. So far, we've been able to have a dentist, members of the Washington HPV Task Force, and an AAP member review our materials and provide feedback. And so just to touch on a couple points that we've received so far, the first was really to emphasize that preteens and teens see their dentist more than they see their primary care doctor. And this holds true in rural communities as well. So this represents a huge missed opportunity to have these discussions and then for dentists to vaccinate if they're able. And then additionally, some feedback we've received, and it's something Nicole and I also kind of went back and forth on, is consistent terminology in, is it oropharyngeal, oral cancer, or cancer of the mouth and throat? And so based off of our feedback we've received, it was recommended to just say cancer of the mouth and throat. It's the simplest and kind of easiest to understand. And so we've identified a few other individuals we'd like to review this, and that's kind of our next steps. Next. Thank you.
Thank you.
Thank you, Nicole and Heather, for this great presentation showing how dental providers can play an important role promoting HPV vaccination in rural areas. If you have any questions to Nicole or Heather, please use the chat box or ask them at the final Q&A section of this showcase. We'll now have our second group who will be presenting on advancing HPV vaccination at age 9 in American Indian Alaskan Native communities. Let us welcome Mary Robertson and Julia Brown.
Thank you. Next slide, please. Just a really quick overview. We're going to be giving some background about this population and how that's going to relate to some of the disparities we'll be looking at today. And then take a really high level look at some of that data. We would love to have a lot of time to deep dive, but we'll save that for another day. And then also look at some of our deliverables, which is our provider action guide and our parent fact sheet. Next slide. Next slide, please. So before we take a look at anything to advance and appropriate for vaccination, we want to take a look at the background and how we can have a deeper understanding to move the needle. So when we're looking at in America, there's over 6 million American Indians and Alaskan Native people living in the U.S. And then all of those may or may not belong to a federally recognized tribe. So we have over 574 federally recognized tribes and over 200 unrecognized tribes, and that number is probably higher. So these tribes are culturally diverse, they're sovereign, they have different values and symbols and languages, different governance structures and priorities. So those are all important to take into consideration when we're trying to move the needle for vaccination. Although they live both in urban and rural spaces, the largest populations are in our western states. And then also when we're talking about vaccination and cancer access, we need to think about where is this group seeking care. And so that is a variety of sources as well. So we have the Indian Health Service, which you can see the map of the right is the locations that they have in every state. There's also our tribal health programs, our urban Indian health programs, and our non-American Indian affiliated health systems. So those would be our more Western traditional primary care offices. Next slide. So taking a look at some of our missed opportunities and what the data is telling us, cancer is a growing concern for this community, and it is the #1 cause of death for women and the second leading cause of death for men. So definitely of high importance. And then compared to our general population, we're seeing that there are higher rates of our HPV-related cancers, especially for our cervical cancer as it relates to women. And then our women of American Indian, Alaskan Native descent are also having higher prevalence of those high-risk HPV infections compared to white women across the United States as well. Next slide. So whenever we're thinking about our approaches or strategies in public health, we also really need to consider the historical and structural context. So especially for this community, we want to consider the historical trauma and how that plays into receiving care today, and also views and preconceptions about the HPV vaccine. Also, when we're thinking about where they're seeking care, especially the Indian Health Service and some of the more cultural tailored organizations, they tend to be underfunded health systems because they have to serve such large areas and populations, yet they have limited resources. Then there's also the geographic dispersion to take into consideration. So when we're thinking about access, as the map we showed on the previous slide, there's not a service specifically tailored for this community in every state. And so sometimes people might have to travel a far distance for that tailored care, or even having transportation and the ability to get there. So all really important, as well as thinking about this group is often excluded from research and data systems, which that baseline data, which Julia will touch on more, is really important when we're looking at our cancer morbidity and mortality. And then there's also really limited culturally tailored care, and that's something we saw again and again in literature and as we spoke to experts. Next slide. So I'm going to hand it off to Julia, who's going to deep dive into one of our first deliverables.
Thank you, Mary. So our resources, especially our toolkit, are still in development. So we are going to share a really high-level overview of what has been included up to this point. Next slide, please. So our first deliverable is an action guide, and it is intended for healthcare providers who provide care to American Indian or Alaska Native communities. So this can be in association with Indian Health Service, or this can be separate clinics that just serve communities in those geographic areas. And so why is this toolkit important? We want to provide these healthcare providers and their staff with the tools and resources needed to equitably recommend HPV vaccination and decrease differences in HPV cancer outcomes. So we aim to bridge the data gaps that Mary mentioned earlier through the promotion of evidence-based and actionable strategies that we know work. However, for these strategies to work effectively, we must be really intentional about centering recommendations around culture, trust, and tradition, while also honoring the history and tribal sovereignty of these communities. Next slide, please. Okay, so in this toolkit, we include a brief background, much of which Mary already shared, but we do aim to represent the breadth and diversity of American Indian and Alaska Native communities, while also recognizing that they're not all the same. So people who identify as AI or AN may vary in traditions, also in decision-making practices, and especially in physical appearance. So importantly, people who identify as AI or AN may also identify as many other things. So this leads us into our discussion about making sure that we're appropriately classifying demographic information, including race. And this can't be determined by patient's last name, facial features, or area from which they live or come. This can only be determined by asking the patient their demographic information and allowing them to self-identify. But this allows us to have much more complete and comprehensive sources of data to really understand the impacts for these communities in terms of HPV vaccination and HPV cancers. So much of this toolkit focuses on describing the evidence-based strategies that can be employed, but we have also included a case study to demonstrate how these recommendations can be put into practice and also tailored for specific communities. Then we include a number of resources that they can use to learn more. Next slide, please. And so, as mentioned in the background, we previously shared and have summarized in the toolkit, there's really important emphasis on making sure that we have appropriate vaccination data. This allows us to monitor patients and make sure that they are reaching series completion, but we also know that data gaps are a significant challenge. So HPV vaccination data for AI and AN populations are often very limited, and this is due to smaller sample sizes and, as we previously mentioned, classification issues related to race. There is also especially limited research about HPV vaccination starting at age 9 in these communities. And so these data gaps underscore the need for tribally led and culturally grounded research to continue in this area. Next slide, please. So knowing that literature is limited, but existing studies highlight several barriers. So some of these barriers include misinformation, concerns about safety, discomfort discussing sexual health, mistrust of government recommended vaccines, structural access barriers, and many others that are not uncommon for other communities related to HPV vaccination. But for this population specifically, providers must understand both cultural and systemic factors influencing the decision making. So we really have great opportunity to focus on starting HPV vaccination at 9. Many of these reasons will be discussed by other groups who will be presenting on this topic, but we know that it makes it more likely that these patients will complete the series on time, that they'll have a stronger immune response to the vaccination, they will be protected before they are exposed to the vaccine, and it just increases the opportunities that they have across several visits to complete their vaccination series. Next slide, please. So now I'll turn it back over to Mary to talk a little bit more about the actionable strategies that are included in the toolkit.
Thanks, Julia. So this is a screenshot, again, still in progress. We're editing different components of it, but we really want to make sure that our providers and their practices and their care teams really know what to do with the information. So the action steps is really more of a goal, and then the strategies is how they can move towards that. So as you can see, some focus on just age 9 initiation and education. Others might focus on utilizing their EHR better and so on. But again, within our literature, again and again and again, the feedback said that this needs to be tailored information to this community. So we have cultural considerations, which Julia just went over, but we've also embedded those within each action item. So for example, the one that's highlighted is making sure you're consulting the decision maker. So whether that might be an elder, the parent, the chief, again, this is going to differ by community and by tribe. And so having that open line of communication is going to be really important. Another example under like EHR utilization is making sure that they're accurately recording and documenting demographics, especially being able to check multiple race and ethnicities, because that's also feedback that we heard as we consulted experts, that sometimes people of this community only can choose one, and a lot of people that also identify as multiracial. So that contributes to some of the data and research lags as well. Next slide. And so another component that we found helpful and we also wanted to include were some case studies. So again, from talking to folks and getting feedback, as well as you can see highlighted in this article, many providers still feel that they don't have structured training on HPV, let alone those that are serving AIAN communities. And this is especially true even if they're residing in a tribal health center or IHS. Because of the high turnover, they may only be there for a few years. So again, showing the need for this resource and hopefully being able to share those that are really replicable. Next slide. So we hope to share, we have a few case studies from the Cherokee Nation, Hopi, and some other examples. And this really will show the collaboration between a tribe, a community or health center, university, and so on, about how they were able to successfully raise the HPV vaccination rates. And we will have an age 9 emphasis on that. So it's going to feature some that are in peer-reviewed journals, but also that are in other reports, as we recognize that everyone doing this work may not be a formal researcher and then trying to publish in peer-reviewed journals, but they're still doing really meaningful work and lessons that we can learn from. So these case studies will be tribal-led, involve community engagement, show lessons learned, and again, that importance of that culturally grounded implementation. Next slide. So another important aspect we really wanted to include is those AIAN specific resources that already exist. And this is just a highlight of a few, and again, a picture of just a couple. There are several out there. And as we know, providers have very limited time, and so we really don't want to reinvent the wheel, but we wanted to make it really easy and accessible for these items and materials to be found so that we can address the cultural concerns. But again, not having to totally scour the internet so that they can all be in one place and hopefully increase the utilization of ones that already exist. Next slide. However, when we were looking at those materials, we did see that there was a gap and opportunity to emphasize age 9 as they weren't included in most of the materials. Next slide, please. And so that is the focus of our parent fact sheet. Again, really addressing a lot of those cultural concerns that were mentioned in the few studies that we did find that Julia went over, but also emphasizing and utilizing plain language, cultural values, symbols, and imagery. This is a little bit challenging because all the tribes are unique. So we're hoping to really highlight those symbols and values that will transcend instead of focusing on one specific tribe, and really utilizing the power of storytelling in those as well. So the image on the right is not the exact image we'll be using, but illustrates some of the themes that we're trying to come across with our H9 focus. Next slide. So I'm going to turn it back to Julie to talk about our implementation.
Thank you, Mary. And I know we're closing in on time, so what we want to share with you is that our proposed implementation of these resources includes a pilot. So we propose piloting among providers and practices that serve AI and AN communities. We would prefer in an IHS setting initially, and then implementing later in communities that more broadly serve these communities. So this would include establishing a baseline, getting some initial feedback, monitoring and evaluating reach, utility, and also increases in HPV vaccination. And then we would continue to iterate the resources and improve them over time, and then more broadly disseminate those resources as we mentioned. Next slide, please. So as we move forward to finalize the content of our resources, we continue to invite input from subject matter experts and others who identify as AI or AN. This is really important to make sure that we are aligned with cultural relevance and appropriateness for our final product. And as we mentioned, we also realize that it is important to implement among those who would have interest in this project to be able to make those improvements in the content and the design of the toolkit. We're really excited about the potential of this project, and we will welcome questions at the end of all of the presentations. Thank you so much for your time and attention.
Thank you, Mary and Julia, for giving this great overview of the many opportunities to expand vaccination among Native American communities. I see great conversations happening in the chat box, so please continue using the chat to ask questions or connect directly with our fellows. We will now have our third presentation of today's showcase. Let us welcome Ryan and Rachel as they discuss HPVX Navigator, your guide to free HPV vaccination and community support.
Thank you. I'm going to go ahead and jump us off with a quick overview here. Starting with the population of interest, we're going to talk about child health facts and jump into the rationale of our entire project, discuss the goals, strategy and development, review of our Navigator prototype, preliminary usability and acceptability testing, design iterations, and then our future direction. Next slide, please. So first and foremost, our population of interest is those kids who are VFC eligible. So those who are uninsured, underinsured, and Medicaid eligible children who are in need of free or low-cost vaccines. The focus of this project is obviously HPV vaccination, but knowing that most VFC providers are going to have all other immunizations that these children are going to need. So we're getting HPV vaccination rates up, but also covering those other immunizations while kids are in the office. And these patients may also have some additional social needs. So that could include transportation problems, food insecurity, or barriers due to the cost of immunization. And then just to start off with, we are looking at patients who are in Georgia and North Carolina as our initial states for this project. Next slide, please. So some basic facts about these states. North Carolina, 5.5% of kids do not have any health insurance. This puts North Carolina as the 27th out of 51 in the US in terms of kids without health insurance. And 41.3% of kids are on Medicaid or CHIP. And in North Carolina, we launched Medicaid expansion in December of 2023. Compared to Georgia, that has limited Medicaid expansion, 7.9% of kids do not have any health insurance in Georgia, putting them even further down the list at 42 out of 51 in the US, and 41.7% of kids in Georgia are on Medicaid or CHIP. And we just want to note that kids without insurance are more likely to have unmet health needs, and lack of the usual care sources may affect their ability to grow into healthy and productive adults. Next slide, please. So, rationale behind this project is we can see on the right here from that NIS data that HPV vaccination for uninsured kids significantly lags behind those with private insurance or Medicaid. And for all of those patients, significantly lags behind that Healthy People 2030 goal of 80%. Most of these socioeconomically disadvantaged families have positive HPV vaccination intentions, but these intentions do not correlate necessarily to uptake. One piece of that we're trying to prevent is the fact that there may be other barriers to vaccination. So again, taking into account socioeconomic barriers that we talk about, and including a one-stop navigation for all of these resources. So you can find vaccination resources, community resources, and how to get access to those actual immunizations. Next slide, please. So we had a couple of goals. Our really long-term main goal was to reduce the practical barriers to kids getting vaccinated. So how can we get them into the office? How can we easily help them find an office? Our other short-term goal is to really just facilitate the meeting of social needs for these families. Do you need transportation resources? Do you need food while you're in the office? Things like that. And then our other long-term goal is to overall increase the uptake of HPV vaccination in North Carolina and Georgia, and hopefully expanding these to other states eventually. Next slide, please. So for strategy and development, we really wanted to define who this tool serves. So right now it focuses on VFC eligible underinsured and uninsured kids, but knowing that the parent can't find vaccination for themselves, if they don't know where to look, their kids are not going to be up to date. So really serving that broader population outside of just VFC eligible kids. And then we also wanted to understand the need, so reviewing gaps in immunization and insurance status. And at this piece, we utilized community partners to kind of understand where the gaps are from those people who are the boots on the ground in the practices and in the community. And then for MAP access, we got the information for VFC providers from Georgia through data request, and those offices are searchable on our tool. In North Carolina, we're linked to the DHHS site where there's a map and people can search based on zip code, city, things like that. Along with the VFC provider, we also curated resources through the community that'll help fill those social determinant gaps that patients are finding and inhibiting their ability to get vaccinated. And overall, we really just wanted to make sure that this tool was simple to use. The plain language messaging, brief informational content, and make it simple. We want to keep it easy. And from there, we've done some testing The goal is to do 3 waves of usability and acceptability testing, analyze the feedback, and revisions. We have completed the first wave of feedback, and Ryan will talk a little bit more about that and the changes we've made based on that feedback. I'm going to pass it over to Ryan on the next slide.
Thank you. So now introducing our prototype. These are snapshots of the web tool as it currently functions. If you'd like to try it live, the QR code takes you directly to the Shiny dashboard. So web tool is developed on the Shiny app platform. So please note, though, this tool is still under iterative refinement and does not yet reflect the full set of compiled community resource information. And the tool is not yet ready for distribution. The left snapshot shows the desktop view, and the right shows the mobile view. Across the top are the main tabs: Eligibility Screener, VFC Provider Finder, and Community Resources, which help users find practical supports on trusted websites, such as transportation, food, and housing resources, and so on. We also include on About Us tab and a feedback tab that links to a brief survey. So on the home page, the experience starts with the eligibility screener in the input panel. You can try it out with your, I know that most of you are out of Georgia and North Carolina, but just try it out if you want to. Where users select their state of residence, the age of the person they're searching for, and insurance status. We also note that entries are anonymous and cannot be linked back to the users. And we provide a brief disclaimer about the recent guideline update along with our contact information for follow-up questions if they have. And for additional guidance related to HPV vaccination and some more educational materials, users can follow a direct link to the ACS National HPV Vaccination Roundtable resources page. Next slide, please. So here's what the navigation looks like once a user is ready to find a place to get vaccinated. And there's still the QR code in the bottom if you haven't tried it yet. So we designed the provider finder to be state specific because each VFC program makes provider information available in different ways, as Rachel mentioned. For Georgia, on the left, users enter a zip code and the tool returns nearby VFC providers with distance, address, and a phone number. For North Carolina on the right on the screen, the tool needs to redirect users to the state's official VFC site. And Wave 1 feedback made it clear that these handoffs can feel disorienting, so we added step-by-step instructions with a visual cue showing exactly where to scroll and which search box to use once they land on the state page. Across both states, we also surfaced practical information upfront, such as typical administration fees and the policy that children should not be denied vaccination if a parent or guardian cannot pay the fee. And when users indicate that they would like to explore information on social resources, that tab directs them to the Community Resources tab for relevant supports. Next slide, please. After building the first working prototype, we launched early usability and acceptability testing to surface major breakdowns. And recruitment for this survey used a simple outreach flyer with a QR code, the same QR code directs to the web tool. And we specifically recruited parents of children in HPV vaccine eligible age groups. In Wave 1, participants used the tool and then completed a brief post-use survey, which were usability via the system usability scale, and measures like acceptability, appropriateness, and feasibility using the validated acceptability of intervention measure, intervention appropriateness measure, and feasibility of intervention measure. We had 8 respondents for this first wave, and the initial signal was strong, mean score of SUS around 90, with acceptability ratings near the top of the scale. So the goal of Wave 1 wasn't to prove downstream impact yet. It was to generate clear, actionable priorities for the next build. So we for the iterative revisions. And our evaluation plan is intentionally iterative, as mentioned. Wave 1 identifies key issues to refine. Wave 2 confirms that fixes work and reveals next tier friction points. And Wave 3 generates more stable metrics with a larger sample. We're planning for the N of 30 to 40. Next slide, please. This slide summarizes the Wave 1 takeaways. Usability was high overall, with most participants above the commonly used SUS reference threshold of 68. And acceptability feasibility ratings were consistently strong, and we're careful in interpretation, though. With a small sample size, these are descriptive, but they give us a clear signal that the basic concept works, and that the remaining work is about reducing friction. After those survey questions, there was an open-ended comment section, and some of the comments pointed to a few fixed targets. First, clarify the intended pathway so users understand when the next step is to go straight to the clinic or provider search versus to go to the community resources tab. Second, reduce confusion after the North Carolina redirect by improving orientation and instructions. A third theme was adding enough HPV vaccine-related educational materials to build the confidence. Next slide, please. So here are the changes we implemented over design iterations based on internal review, the mentor feedback, and Wave 1 user testing. We implemented a set of concrete design changes focused on reducing cognitive load. First, we removed reword for users. State selection now persists across tabs, so the users don't need to select the state for every tab. And we added a clear start over button to reset the screener and wipe prior inputs when users want to start over the process. Second, we addressed the confusion when redirected to the North Carolina's VFC site by adding a visual North Carolina specific navigation guide that prepares users for the redirect through the link and shows exactly how to complete the provider search on that state site. Third, we made small trust and comfort tweaks, switching the logo from a needle. The original one was needle at first. Now it's a vial. And that was to reduce potential needle trigger reactions and adding an explicit disclaimer about the January 2026 guideline change. The open design decision we're planning to actively discuss next is how much educational content to embed versus keep as optional links as now, because we are not quite sure like if that would distract from the core navigation purpose. Next slide, please. Next steps are about moving from a promising prototype to a sustainable and measurable public health resource. On the infrastructure side, we plan to move from the current free hosting setup to an institutional server like Emory AWS, so we can support secure backend logging and maintenance workflows. On the evaluation side, we will complete the next waves of usability and acceptability testing as planned. And for dissemination and scale, we're prioritizing partnerships with community organizations and state HPV coalitions, expanding to additional states and/or vaccines as the data pipelines mature. And also adding additional language options would be great. We are especially hoping to collaborate with community partners to curate, verify, and share local social support resources because over time, we would like to build more resources, community resources, information. And also we're aligning this work with an ongoing Texas-based ACS funded project, qualitatively examining facilitators and barriers among VFC eligible families. Ultimately, our goal is for this HPV vaccine navigator to function as a living, regularly updated resource and not one-off tool. Next slide, please. That's all for our team. We'd love feedback on what would make this more usable for families and implementable for public health partners. So please reach out to us if you're interested, and if you have any feedback on questions. Thank you.
I want to echo the comments in the chat box. This is an amazing tool to give access to HPV vaccination information and community resources. So congratulations on your work, Ryan and Rachel. We will now have our final group who will be presenting on understanding HPV vaccine uptake in immigrant communities and building provider resources. Let us welcome Dominic and Charlene.
Thank you, Dr. Callow. So I'm going to start off with a little bit of background. In the United States, cervical cancer have markedly decreased due to HPV vaccines and cervical cancer screening. There remains entrenched geographic disparities in cervical cancer incidence and mortality. So more specifically, regions with the highest burdens of cervical cancer are largely confined to the southeastern and southwestern United States. And this is due to several factors, so structural barriers and socioeconomic barriers. However, one factor that looked is demographic shifts in immigration and migration, specifically population growth amongst individuals who originate from regions or countries with historically higher cervical cancer burdens and lower access to preventative screening. So when we're looking at immigrant and migrant women specifically, they tend to experience higher rates of cervical cancer compared to the general population of the United States. Take of preventative measures, both vaccination and screening, tends to be low within this community. Next slide, please. So in regards to HPV vaccination more specifically, HPV vaccination rates amongst children of immigrants and migrants tend to be suboptimal. So currently in the US, about 18.1 million children live with at least one foreign-born parent, have completed the full HPV vaccine series, which is significantly lower than children of non-immigrants. And even fewer have initiated the vaccine at age 9. So as we know, when we're looking at low vaccination rates and challenges and barriers in regards to vaccination rates amongst children, we must consider the essential role of parents. So numerous studies have shown that across others tend to be the priority or the familial health decision makers across families. And while there are noted differences in regards to challenges in HPV vaccination uptake across children of immigrants, there also tends to be overlapping barriers. So these overlapping barriers tend to be lack of awareness in regards to HPV and lack of knowledge about the availability of the HPV vaccine, factors such as HPV vaccine cost, alongside reduced touch points with the healthcare system, which is partly driven by immigration status. Next slide, please. So, as mentioned, parents are essential and critical in facilitating HPV vaccine uptake amongst children. So, targeting parents, especially mothers who are the primary health decision makers for families, may be key in facilitating HPV vaccination coverage amongst their children. So, we know from the literature, immigrant mothers tend to have fewer interactions with the health system overall. Once again, this is partly due to immigration status. However, we also know that they tend to engage with the health system more consistently at key touch points. And these key touch points tend to be during the perinatal period, so during prenatal and postpartum visits, during well woman's visits, and during well child visits. So these key time points may present opportunities to discuss cervical cancer prevention using integrated approaches that target both mothers and their children. So for instance, a study conducted in the US that included reproductive age mothers found that well woman's visits amongst mothers was associated with higher HPV vaccination uptake amongst their daughters. So these visits may represent opportunities for counseling and education using an integrated approach. So discussing cervical cancer prevention for both mothers and their children. And by utilizing an integrated approach, we can really shift from using from implementing isolated preventative conversations to more so incorporating an intergenerational cancer prevention strategy. And such an approach may perhaps propel mothers, specifically immigrant mothers in this case, to take action in vaccinating their children starting at age 9, while once again also engaging in preventative efforts for themselves. In undertaking this approach in regards to this integrated health communications framework, we focused on FQHC settings, given that these settings tend to focus or tend to serve large immigrant and migrant communities, while also providing comprehensive wraparound services. So these settings can really be opportune in really targeting cervical cancer prevention for immigrant mothers and their children. Next slide, please. So for our project, our aim was to develop an evidence-based summary and resource kit to aid FQHC healthcare providers and staff in integrating cervical cancer prevention conversations at key healthcare touchpoints for immigrant mothers with HPV vaccination eligible children through tailored integrated approaches. Next slide, please. So now I'm going to discuss the landscaping that we did to support our project aim. So we initially conducted a literature review, and we found that much of the existing literature focused or tends to focus on HPV vaccination within pediatric and adolescent settings, with comparatively little attention to alternate health system touchpoints, particularly for immigrants and migrants. In addition, there tends to be limited evidence in regards to utilizing an integrated health communication approach for cervical cancer prevention that targets mothers and children. Many of the studies that have been conducted that use this integrated approach have been conducted outside of the United States, particularly in Southeast Asia and Sub-Saharan Africa, but not as much has been done here in the US. So this represents a critical gap. And potentially addressing this gap may be particularly important for immigrant communities who once again experience persistent barriers to preventative care and also experience disproportionate cervical cancer burdens. Next slide, please. We did an evaluation of patient-facing tools as part of our landscaping, and we found that there were numerous patient-facing tools that focused on HPV vaccination, specifically starting at age 9 for immigrant and migrants. The majority of these resources were developed in Spanish. However, there were other resources developed in alternative languages as well. And many of these resources, once again, emphasize vaccination at age 9. However, we were not able to find resources or communications tools that really utilize an integrated approach for both mothers and their children. And in addition, there were not too many resources that were tailored for specific healthcare settings, specifically FQHC settings. Next slide, please. We then evaluated provider-facing resources, and we found that a lot of the resources for providers that were supposedly tailored for immigrant communities were very generic. They provided general guidelines in regards to HPV immunization for immigrants and migrants. However, there were not many resources that were healthcare settings and that provided input in regards to approaches that can be used to generate motivation for vaccination amongst children of immigrant mothers, alongside tailoring that with prevention recommendations for immigrant mothers themselves. Next slide, please. The FQHC that I currently work in, and I saw that there's a really essentially limited information in regards to HPV vaccines, that HPV vaccination and cervical cancer prevention approaches immigrant mothers and their children. The FQHC that I'm based in serves a large immigrant community. However, despite this, there was nothing in regards to cervical cancer prevention from a screening standpoint or an HPV vaccination standpoint. And what I found in my clinic follows trends that are observed in other FQHCs nationally. Next slide, please. Over to Shaylin.
Great. So I'm going to talk about how we took steps to convert some of the evidence that Dominique just described into action and some provider resources. Next slide. So as Dominique described, we reviewed a lot of the literature. We also reviewed examples of existing action guides and toolkits and what is available already. We compiled all of those. Then we went through the steps of trying to adapt some of that evidence, as well as the developing some of these supplemental resources. Next slide. And so the first main thing that we worked on was compiling evidence in this space. There really is a few systematic reviews, but there wasn't a lot on this on the Roundtable's website. And so we thought this was a great opportunity to kind of summarize the evidence. So this is an integrative review. It includes diverse evidence types like qualitative and quantitative research, as well as meta-analyses and systematic reviews. It's set up as a bit of a living summary, so it can be updated if new evidence emerges, and it uses the kind of format that the Roundtable uses for all of its evidence summaries, grouping it by what do we know, what's known, what is new, and then what is next and recommended. Next slide. And so we took all of that information after kind of compiling that evidence summary, and then that really helped to illuminate what are some of the unique barriers and needs for this population, what are general population approaches or interventions that work across the board that may also be applicable to immigrant populations, and then what needs to be adapted specifically for immigrants. And then all that information helped feed into our provider toolkit. Next slide. So here's a mock-up of our toolkit. As Dominique said, it's really aimed at federally qualified health centers, but the title is a bit broad in case there are other situations in which this could be useful. So we have kind of it framed around providers that serve immigrants and their families, though an FQHC setting with wraparound services is ideal. Then we get into kind of summarizing that evidence very briefly, like making the case for why this population matters with a bit more of a visual approach and less of the content that's in the evidence summary, but very similar. Next slide. And then we get into some of the strategies to increase HPV vaccination among immigrants. And so these are a mixture of ones that are kind of standard for the general population with some additional content around how this matters for immigrant populations, as well as some strategies that are specific to immigrant populations. So like for the general population, delivering clear, strong, and early recommendations is imperative. And we walk through some of that for that strategy. The content that Dominique was getting into around these touch points across the life course, right? This integrative approach is really the second strategy here that we get into, and it really expands upon all the ways in which reaching immigrants through this expansion of these touch points with the healthcare system is a key strategy. And then obviously having patient materials in appropriate languages is very key, since we know that folks who receive recommendations in their native language are more likely to accept that recommendation. And then the last two strategies are really around integrating recommendations and strategies into clinical workflows and reminders for patients and providers. These can be customized to immigrant populations and also to the general population. And then reducing access barriers as well. And I think you already clicked to the next slide, but each of the strategies is grouped into kind of some key action kind of content around what do some of these actions look like, what are additional resources that folks might want to reference, and then some links and key resources at the bottom of each strategy section. If you go to the next slide. And then the supplemental resources. So we had 3 that we've pulled together that we think are going to be useful for providers trying to engage in this work. The first is something that Dominique led around tailored conversation starters and strategies for providers. And this really gets into if you're bringing up HPV vaccination, whether it's a recommendation or just a conversation to build awareness at a non-traditional touch point like a well woman visit. Times in which we aren't traditionally coaching providers to make HPV vaccine recommendations. What could that conversation look like? We also have a sample PAP or HPV test result letter for someone who is receiving a negative test result, embedding an HPV vaccination recommendation into that. Could be a good strategy, again, an additional way to reach this population and make a recommendation in a not less traditional setting or time point. And then we also have a provider survey that might be more useful in the context of a quality improvement project to address HPV vaccination rates among immigrant patients. Next slide. And then we also have some considerations around evaluation. So for the toolkit and the resources, I think there are opportunities to obtain input from roundtable stakeholder group or other experts to measure counts and downloads of the resources themselves for utilization, and then also potentially a rubric to better assess usability and the overall kind of usefulness of the resources themselves and the toolkit. And then if this work is going to be implemented within a healthcare setting, right, there are other considerations for evaluation that we thought through, including interviews with providers and staff, a pre-post survey for providers like the one on the prior page that would get at beliefs, confidence, intent to recommend the vaccine, et cetera. And then also, taking into consideration and measuring changes in the availability of patient and provider-facing resources, those that are in various languages, as well as changes in vaccination coverage or reduction in missed opportunities for vaccination. And next slide is just a thank you all so much for your time and attention.
Good afternoon, everyone. My name is Gabrielle Darville Sanders. I currently serve as the Strategic Director for the National HPV Vaccination Roundtable, and I will be serving as the moderator for the Q&A session. So thank you to our presenters for today, and thank you, Shaylin and Dominique, for overviewing your wonderful presentation. I'm going to go ahead and invite all of my fellows to join me back on screen to facilitate such an engaging part 2 to the conversation. So well done to our first half of our cohort. Hopefully you guys can breathe a little bit. I immediately saw a smile come to some of your faces having navigated and went through that presentation. I don't know if you guys have been paying attention to the chat, but you're getting so much love for the amazing work that you guys have done. And we are excited to see what round 2 is going to accomplish tomorrow. Bear with me, as the fellows know, my voice is trying to go away, and so I might have to tap Dr. Kalo to come back, but we'll facilitate some great Q&A discussion about your presentation. So I do have some questions that were dropped into the chat. So the first group, excuse me. So group 1, which talked about dental providers and rural populations, Heather and Nicole. One of the questions that you guys got was, how do you plan to support the uptake of the toolkit? And do you have any plans to evaluate or how people are using it,
Nicole, do you want to, or I can?
Oh, I can go ahead.
Okay, go ahead.
So our next step will be to engage more in the implementation phase as well as piloting. I'm going to put out a shameless plug here. If anyone is interested in piloting some of these materials, please let us know. We can drop our contact information in, but that'll be our next step in this process.
Okay, awesome.
And I'll also, real quick, I was just going to add, here in West Virginia, there's a huge movement among dental providers and the Cancer Institute, and they seem very interested and invested in the HPV vaccine here in the state. So that's also an opportunity as well that we've, Nicole and I briefly started talking about as I learn more about my new institution.
Awesome. Well, that's amazing to know that there's capabilities and opportunities. I know in creating your toolkit, you talked a lot about the radio script and the birthday card. Can you guys talk more about the process that you took to develop both of those? Because, I'm a millennial, and, radio, who really listens to the radio? Like I probably wouldn't have thought like, let's do a radio ad, but it sounds like it's a very fitting approach to the population you're trying to reach, right? So can you talk more about your process and the development and the feedback you got to kind of get it to where it is now?
Yeah, our work was pulled from a lot of evidence-based interventions that have occurred in rural areas. So we saw that radio ads are still very applicable in these areas and widely used and can create a broad reach to the general community, especially for folks that are commuting to work or just have the radio on in general. And then in terms of the birthday card, we got some really good feedback from a few dentists that said that this material would be really helpful. A lot of I feel like in my personal experience, I always get an email from my dentist when it's my birthday. And so I thought that this would be a great way to segue that conversation of HPV into that birthday conversation.
Sounds like you have a great dentist. I might need to change
Yes.
dentist providers. Um, a follow-up question for group one. So obviously, and this is probably a group that's going to apply to all of our groups. Obviously, there's been some vaccine schedule changes, which may influence the uptake of the work that you guys are currently doing. Specifically for Nicole and Heather, how do you think, or have you considered, or do you anticipate rural oral healthcare providers, impacted or may not be as flexible or be as open given everything that's going on?
Again, as I mentioned earlier, and I'm just now starting to kind of learn the ins and outs of healthcare here in West Virginia. But being a largely rural state, it's the only state that's completely in Appalachia. I feel like it kind of fits this. And like I said, I've learned here that there is a huge push and there's a lot of interest and enthusiasm with dental providers in the state. So in my experience with that, I know it's very limited. I haven't seen anything that kind of leads to think that the changes and the things going around with the vaccine schedule and recommendations right now has impacted that negatively or has kind of made them shy away from it. It still seems like that has a lot of steam and interest behind it. So I'm hoping that that is representative of the larger picture.
Awesome. Thank you, guys. So shifting to Julie and Mary, very comprehensive presentation. Great feedback provided in the chat from those who have listened to your presentation. You focus on a very population that we haven't done a lot of work in, and you acknowledged that in your presentation, right? And you talked a lot about like the cultural considerations and values and beliefs of the tribal communities and Alaska Natives and American Indians. So thinking of that, some of these providers that do provide care, there may be high turnover. How do you think that will affect, or have you planned for that in the dissemination of the toolkit, especially as you may go through some updates and revisions of it?
Yeah, I can start, Julie, if you want. So we have started to talk about that. We have spoken with staff at Indian Health Service and that being part of the challenge. So we've actually spoken to them about potentially doing an echo where we can feature the toolkit, but also feature actually someone from one of the case studies or one of the other case studies they're more familiar with to kind of kick it off. And then we've also reached out to the American Indian Cancer Foundation as well. So hoping to use those. Again, I think I saw in one of the comments again, the trusted partners who are already working with the providers that we're seeking. And then specifically to address the high turnover, I think it's just going to have to be one of those repetitive push, which is what we're hoping that these organizations can push out. And as part of our communications plan, we're hoping to implement. But again, I think we know repetition is key for any population. So I think it's just something we'll have to keep pushing, but we're really trying to use those trusted channels. It'll mean a little bit more to come from.
Awesome.
I think just to add to that, this is something that we could really push to be included in the orientation of new clinic staff or providers. So even if we tailor the contents of the toolkit to just be a slide or two that is routinely included when new team members are onboarded, then I think that they would also have the benefit as new team members of just knowing what the expectations are around HPV vaccination for that specific clinical practice. And I think something that Mary and I have talked about was how humbling it was to just not know. Like, we don't know what's culturally appropriate or acceptable. And so just being open to learn and explore what these scenarios look like for different patients and families is something that we can also kind of center the providers around this thought process. It's like you won't know how every patient will react, but if you at least create a routine around recommendation, then you give every child the opportunity to have that protection equitably.
Yeah, and I think one of the things that I really enjoyed is that your group, I mean, I think sometimes we think we have to recreate the wheel, but you use existing case studies and use existing tools as part of the larger toolkit that has probably been tested and has been utilized within that target population already. And so it's kind of like, I'm not a member of that community. Why do I feel the need to recreate something that's already out there? But are there additional tools that we can add to that will help improve the vaccination rates among this target priority population? And so I think that it's a well done job of looking to see what's out there first before you thought through, like, how can we? And then utilizing, obviously, the trusted messenger and trusted organizations within that community to think through the implementation of that. So kudos and well done.
Thank you.
No problem. So I'm going to, and I think in the chat, I did see someone said love an echo. If you have ever interacted with ACS, we love a good echo. So echo, and I did see someone said that they were really interested in they're definitely interested in using them in their state of Oklahoma. So you do have some interested individuals who see the usability and the implementation of that within their target population. So good job. Group 3, Ryan and Rachel. So you got a lot of comments about the usability of your digital tool. Let's take a step back and have the conversation. How did we land here? Why this tool? Conceptualize. Help us conceptualize. How did we think through the development of your specific tool?
Yeah, thank you for the question. So as I just started to search free HPV vaccine near me, and I noticed that people might just face some walls finding the actual places. It depends on the state, actually, because state Department of Public Health or HHS, they might have the web tools or some guidance on their websites, but some states don't. So I noticed that it might be really hard unless they actually call in, make the time to call in and ask the questions. And sometimes it's not always possible. So, okay, it might be great to have some sort of a web tool that we can regularly update to find these providers, FVSA providers, especially for those who are uninsured, underinsured, and so on, to have free vaccine with a minimum admin fee. So that's why, well, we would like to make something. And although I know that the caveat is that you have to have an access to internet for now. So we plan, I mean, I know you didn't ask this, but we also plan something like, if there's any kind of course, the traditional way is calling in, and we would like to partner with the regional, like in events, for example, to disseminate, but also ask around people if this is actually a good way for people, like most people, to access to the information as well.
Awesome.
Yeah. And we really wanted to make it like a one-stop shop. Like, okay, you can get free vaccine, but how do you get there?
Yeah.
And if you have other needs while you're there, or if you're at a health department, can you get something else taken care of while you're at the health department? And really making it as easy as possible for parents to get their kids and themselves vaccinated through combining basically already available resources into a spot where everything can be found in one place.
Yeah. I think that's important because I think right now we're so bombarded by tools and resources and websites and trying to find things on so many different avenues. And I think that we assume just because people are literate that they are digitally literate or they know how to navigate getting access to information. And so I think you help us by eliminating some of those barriers and accessing the information that they need to navigate how to get the healthcare. I see in the pilot you started in Georgia and North Carolina, and I know that's kind of where you guys are both located. Are there any thoughts about expanding to other states?
I'm kind of hoping to expand it to Florida
Okay.
right now, just because I have collaborators there
Okay.
and hopefully more, of course. But
Okay.
also expanding for other vaccine types because
Okay.
these are the VSU providers and they provide other vaccines as well.
Yeah. I just put you on the spot, not knowing even what the bill looks like on the back. I'm like, yeah, can you expand that? Can you? And Ryan's like, you don't even know how hard it is to do all this in the back end. I just put you on the spot, Ryan and Rachel. I am so sorry, but I think it's a really good tool. And, if there's expandability, I think it could really help, target some of these communities who need access to that. So, um, okay, so group 4, Dominique and Sheila talked about immigrant populations. We had a question about the growth of the immigrant populations. Where do you see the biggest growth of the immigrant populations? Is it more in rural or urban? And are there certain pockets? So I know it's 3 questions in one, and I struggle with 3 parts in one. So first question is, where's the biggest growth of the immigrant population that you've seen trends?
I can take a stab at that.
Yeah.
So over the last few years, there have been a lot of shifts, and that's primarily been due to prior policies and laws that were implemented by the previous president. Previously, we saw a lot of immigration or migration to urban areas. But more so recently, it's been more so been towards rural areas. I can speak on behalf of Maryland, for instance. Over the last few years, we have not gotten a huge influx of immigrants to high density urban areas such as Baltimore. A lot of the influx has been in more so rural areas because what you find is that that's where a lot of companies such as, for instance, like Purdue Chicken Farms, companies such as that's where such as those tend to be based in more rural areas. That's where the job opportunities are. And then additionally, the lower cost of living drives a lot of immigrants to those regions. So definitely rural areas and definitely within the southeastern and overall the southern United States. So southeastern and southwestern United States have been key regions in regards to immigration and migration. Of course, as of right now, things have shifted. Net immigration has gone down significantly due to administrative policies. But I would say prior to 2025, it definitely was concentrated in the southern United States in rural areas.
Okay. Um, and so the pockets are more so in the southeast is what you're tending to see overall. Okay.
Many of those pockets,
Yeah.
there are still individuals, of course, migrating to urban areas, especially in the Northeast, but the Southern United States has seen a huge shift.
Okay. I'm thinking about your work specifically for immigrant, because we know under the immigrant umbrella, it's such a broad spectrum, right? So there's immigrant, there's first gen, there's refugee, there's asylum seekers. Are there additional special considerations that, we should think about? And I think I love your toolkit because I know you also included like a survey that you guys develop as well as some other tools. But are there other special considerations outside the complexities of where they live that we should take into consideration? So, you talked about the mom-child dyad, screening and vaccination, right? Are there even like terminologies? And I know that's going to be very different depending on the immigrant group that we reach, but certain things that we may say as cervix that they say other words that we need to, be mindful of. And I know we're not going to have a catch-all today, but what are some special considerations when we think about vaccination and screening? That may have to be a part of those provider conversations. Because I saw, in the chat, I would love to get access to this tool because I do have a large immigrant population that I serve, and helping me learn more would help me be a better provider. So I don't know if you tracked my question, but Shaylin?
I can give it a go.
Yeah.
I think, Dominique talked a lot about that integrative approach across the life course. I think some other things we saw in the literature that might be helpful for providers to consider included things like the primary decision maker. So when having a conversation with a woman, if she is the one making the decisions or if she includes her partner in those decisions, there is an increased likelihood that they will uptake a recommendation compared to immigrant mothers who may rely on a partner to make the decision for them, right? So there may be some nuances. I think there's so much variability of where people come from and how that impacts their decision making. And I think providers cannot be responsible for knowing all those things. But they can provide resources in the appropriate language and they can try to increase when and how they communicate. And it may look more like awareness building, right, in some cases, than just a clear recommendation. It may be both in the context of this population, to help improve likelihood of uptake of a recommendation later, right? That awareness needs to be built at every opportunity that it can be.
Yeah.
I don't know if that got at your question, but I tried.
Yeah, it's a compounded question. I'm sorry. After I got done, I was like, that was a very dense question. But no, I think you bring up good points in that, a lot of times when we talk about starting at age 9 or starting, proactive vaccination, we say, use the announcement approach. And then if it doesn't work, then circle back at the subsequent visit. And it's obvious from the conversation and talking about immigrant populations, we kind of have to take a step back and just even bring awareness before we can get to the announcement and to the counseling to get them to get that first dose. Because for a lot, I would assume, population group may not even be aware of the need to vaccinate their child for HPV and or get the screening they need for cervical cancer prevention. So I think you bring up really good points. There was a question in the Q&A that talked about a lot of you guys focus on some integration of the provider, right? And trusted messengers. Can any of you guys speak to how you have or plan to engage in using those trusted partners, providers, and messengers to continue to finalize and reach the desired population? So feel free to jump off of mute if you want to talk more about that. And some of you guys had hinted at it in your presentation, so. I don't want to have to call in the group. Please don't make me do it on screen.
I can jump in here and
Go
just
ahead,
say that we proposed piloting in an Indian Health Service setting initially. And I think that that's a good opportunity for us to have a focused population where we know that the providers are serving the community that is targeted through our toolkit resource. But we know that not all children seek healthcare services at Indian Health Service. And so I guess that's why, it gives us the opportunity to kind of build the content, to build the design and make sure that it is the most appropriate resource before we bring it to scale. But then when we bring it to scale, we will very intentionally include other providers and practices that have like a greater breadth of a patient population that includes our target population of American Indian and Alaska Native.
Awesome. Anyone else?
Well, in
Rachel?
the roundtable word, we really look at engaging those weavers. So the people who know everyone. One of the people that we sent the survey to was a mom in my neighborhood who has a daughter who's in HPV vaccination age. And she shared it with other parents who have kids in the same age range. And so she would be another person who we'd continue to engage in future iterations because she knows everyone and can share it with multitudes of parents to do testing.
Awesome. It's great to know some weavers. I'm so glad you brought that up. I'm secretly a weaver as well, depending on the context. So I want to go ahead and wrap it up for today. Thank you guys for such an engaging presentation and an engaging discussion. And I'm so glad that my voice decided to stay for this portion as well. I will go ahead and just thank Also, our advisory board members who you see on the screen for serving as mentors to our fellows and their capstone projects and for engaging them over the last year. We could not have had a successful program without our advisory board members. So shout out to these amazing volunteer leaders. And congratulations to our cohort. So congratulations to our 2025 Emerging Leader Fellows. So proud of what you've achieved and will continue to achieve, and highlighting it today via the showcase, as well as the toolkits that will come later in the year. So next steps for us, as a result of this showcase, the slides will be shared, the slides and the recording will be shared later on. So be on the lookout after the completion of our showcase part 2 tomorrow. And we just ask that when this webinar ends, please go ahead and complete our evaluation survey. The link will be available after we conclude. Thank you guys for joining us today, and have a great remainder of your day. See you tomorrow.